This is Daniel Nevitt and Kevin Holte's pain presentation. No pain, no gain, right? Think again. Pain is a sensory and emotional experience associated with actual or potential tissue damage. Pain can be classified as either neuropathic nerve pain or nociceptive pain. The etiology of neuropathic pain can vary depending on the cause, but all neuropathic pain involves diseases related to or damage to the nervous system. Common causes of neuropathic pain are spinal cord injuries, diabetes, infections, and nervous system disorders. Neuropathic pain is typically described as numbing, burning, shooting, stabbing, or electric.
Nociceptive pain is caused by injury to cells which stimulate pain receptors that recognize and react to a stimulus, such as pressure, extreme temperatures, and irritating substances released by other cells. Receptors then send pain signals through the peripheral nervous system to the central nervous system for recognition and response to an injury or the possibility for injury. Examples include sprains, fractures, burns, bruises, inflammation, obstructions, lacerations, abrasions, and myofascial pain.
So, the process of experiencing pain begins with noxious stimuli, such as tissue damage, that release sensitizing chemicals such as prostaglandins, bradykinin, serotonin, substance P, and histamine. These activate nociceptors and lead to the generation of an action potential, which sends the message up the nervous system. The message travels to the spinal cord, is processed in the dorsal horn, and then up to the thalamus and onto the cortex. Here in the brain, signals are processed and then modulation occurs. In modulation, descending pathways are activated, which can either facilitate or inhibit this ongoing transmission of the noxious stimuli.
Risk factors include tissue injury, diabetes, nerve injury, chemotherapy treatment, autoimmune disorders such as multiple sclerosis, amputations, and psychological factors, anxiety, depression, can cause an increase in the perception of pain.
So when we're assessing pain, we need to look for all the signs and symptoms. Signs of pain can be tachycardia, increased respiratory rate, increased blood pressure, anxiety, reduced bowel motility, depression, withdrawal, loss of sleep, and reduced appetite.
What do you think this man's pain score is? 8 out of 10, 9 out of 10? The client's pain score is always what the client says it is. Assessing pain, do it frequently. Remember PQRST. Provocation, what makes pain better or worse? Quality, what does the pain feel like, such as aching, burning, throbbing? Region or radiation, where is the pain? Does it radiate to any other areas of the body? Severity, usually described on the 0 to 10 scale or the Wong-Baker scale. And T for timing. What time did the pain start? How often does it occur? And how long does it last? You must document your pain assessment and any interventions performed. Don't forget to reassess your client's pain 1 hour after implementing any interventions or according to your facility's policies.
So we have many treatments to address pain and many medications. The first line is non-opiate analgesics, NSAIDs, ibuprofen, and Toradol, and other medications such as Tylenol. When we give these, we should be aware that they have strict maximum dosing because of renal and hepatic toxicities, and should really only be given for moderate to mild pain. They can be used with opiates to bring down moderate pain to severe pain, but should not be used alone for severe pain. Opiates, they're our go-to for moderate to severe pain. Medications like oxycodone, fentanyl, and hydromorphone. So we need to be really careful when giving these medications because they reduce the respiratory drive and can lead to respiratory arrest and not getting enough oxygen perfusion to the brain. So whenever we're giving these, we should assess respirations, do a full pain assessment. If we have the capability to monitor SpO2, we should put that on. These medications can sedate patients, so we should assess the LOC, making sure we're not sedating them too much. Any patient on long-term or really short-term opiate therapy should be monitored for constipation because these can definitely cause decreased motility. So laxatives are often given with opiates, as are antiemetics because they cause nausea. So other pain medication or medications that might be given for pain that aren't classified as true pain medications run the gamut. Some tricyclics and anticonvulsants are really good at treating nerve pain. Some medications like ketamine can be used in opiate tolerant patients where the proper opiate dose to decrease pain might actually put them into a respiratory distress scenario. All of these, and we have a lot of antiemetics we give with, pain medications like Phenergan to reduce nausea and opiates. So all of these should be thoroughly researched before given because they all have very specific properties and routes in the body.
There are many adjunctive therapies for pain management. A few of them are botulinum toxin, also known as Botox, transcutaneous electrical nerve stimulation or TENS unit, and acupuncture. Botulinum works by preventing neurons from releasing acetylcholine. Acetylcholine plays a part in the perception of pain by the central nervous system, although the exact process is not clear. The exact mechanism of how electrical stimulation decreases pain is unknown as well. The current belief is that with electrical stimulation, the sensory nerves become overwhelmed and the pain signals are not able to be transmitted. Acupuncture has been used in traditional Chinese medicine for over 3,000 years to treat a variety of illnesses. How acupuncture provides pain relief is not completely known. Leading scientific theories on acupuncture's mechanism of action are the placebo effect, diversion, mood improvements due to the intimate nature of the procedure, and the cyclical nature of the illness.
Thank you. That is all.